I'd like to, are all our speakers there today?
I am present. Yes.
Yeah. Present. And welcome to the session on Neuroophthalmology. We have, in order to save time, we have decided to project our speakers' brief biodata. Well, their brief biodata is quite difficult to ask for, because it's like writing the entire Mahabharata on a grain of rice. Looking at their biodata is quite extensive. So without further waste of time, I would like to invite all my good friends and colleagues and new friends that I'm making today to start the session, and I'll hand over the podium to Dr. Kavita.
Thank you very much, sir. I'd just like to add 2 points about Dr. Mahesh, which I've heard from my colleagues who have finished their fellowship from Arvind. And I've heard a lot about Dr. Mahesh. 2 things is that is a very, very humble person and down-to-earth person.
Ditto.
And he has all the time. You also told me that, sir. And he has all that time and energy, I don't know from where, and I wish that God gives him more, that he can clarify or clear, sit patiently and talk it out to the students and others. I mean, needn't be students all the time. I think it is just a discussion. And any doubt, silly doubts under the sky, and easily approachable anytime. So in Kannada, I think they say, Tumbud kuda koda tulkadilla anta. But I think in English version, I want to tell it in a reverse way. Empty vessels make more noise. So if the vessel is full, it hardly makes noise, but the depth and the knowledge that one has, I think it is seen in Dr. Mahesh. I now would like to request Saujanya to play on the video.
A very good afternoon to all. First, I would like to thank the organizers of this conference for having invited me here for this meeting. The topic given to me is emergency neuroophthalmology. Now, why is emergency neuroophthalmology important? Every neuroophthalmic case is a potential medical and ophthalmic emergency, and failure to identify it at the right time will potentially cost the life of the patient presenting to us. And that is the reason why this topic is very important. We will do it on a case-based approach. Case 1 is a 35-year-old male presenting with complaints of severe headache of 1-day duration. So his main complaint is headache with a few episodes of vomiting. His blood pressure was normal, a little high, and visual acuity in the right eye was 6/9 and the left eye was 6/6. Fundus showed temporal pallor of the optic disc in both the eyes. So this was his ophthalmic findings. What you can see here is he has got a moderate degree of ptosis here and some amount of exotropia here. He essentially had a right third nerve palsy with pupillary involvement, and the fact that he has come with an acute onset of headache means that it has to be emergently neuroimaged. And an initial CT scan which was done because of the urgency showed a mass in the cellular fossa, and subsequently an MRI scan showed a mass in the cellular fossa, a pituitary tumor with varying intensities of hyper, iso, and hypo intensities, which is suggestive of a pituitary tumor with bleed inside the tumor, which is otherwise called as pituitary apoplexy. So this pituitary apoplexy can present to us with an acute onset of headache or with a third nerve palsy with a pupillary involvement. Any third nerve palsy with pupillary involvement is an emergency. So the traditional teaching is that a third nerve palsy with pupillary involvement could be an aneurysm, and it could also be this sort of an apoplexy, which is also a medical emergency. So the treatment of this patient is identification first, stabilize the patient because these patients have hypopituitarism. High-dose corticosteroids have to be given preferably in cooperation with an internist and an emergency physician. Administer appropriate endocrinological replacement and combine with transsphenoidal surgical decompression of the tumor by the neurosurgeon once the patient is stabilized. The next case is a 45-year-old female with painful left side ophthalmoplegia and proptosis. A painful ophthalmoplegia is an emergency. So you can see the visual acuity is 6/9 in the left eye. She is not a known diabetic or a hypertensive. So this was a presenting complaint, presenting signs. You can see this lid edema. Here complete closure and a lid edema. And when we lift the lids, you can see some degree of chemosis there and minimal degree of proptosis. You can see there is a restriction of the extraocular movements in the abducted position as well as in the other directions. There is some degree of, if you carefully note, there is some degree of dilated episcleral vessels here. You can see here the eye, and here the eye is quite congested and red. It shows that it is a, which is probably a dilated episcleral vessels, along with restriction of ocular motility, along with lid edema, should warrant a blood sugar estimation which is very high. She was not a known diabetic. And together with these findings, it's likely an infective pathology. And a neuroimaging was done which showed that, you can see the salient features are in the cavernous sinus. You can see there is a filling defect. And you can see a dilated superior ophthalmic vein here in the orbit, which indicates that there is a backflow resistance. And you can see there are also congested extraocular muscles and a dilated superior ophthalmic vein. You can see here this dilated superior ophthalmic vein in the axial sections. So this filling defect is due to cavernous sinus thrombosis, usually a late complication of infection of the central phase of paranasal sinuses, usually bacterial, but not uncommonly mucormycosis can also be the inciting factor, especially in diabetics. High-dose antibiotics and systemic antifungals have to be given. It is a life-threatening emergency and care of internist is must. Also, in suspected case of mucormycosis, we have to look into the palate for any necrotic patches. And you can see here, as operated by the neurosurgeon, all these necrotic patches which are seen classically in mucormycosis. Case 3 is a 2-year-old girl child with sudden onset of abnormal head posture of 1 week duration. There was a right head tilt and early papilledema. So it's a young child with a sudden onset of a head tilt, the papilledema. So this is an emergency presenting to the ophthalmologist. You can see this acute onset of the head tilt, and you can see this emergent neuroimaging showed a mass in the posterior fossa. So any recent onset of head posture in the young child should warrant a neuroimaging and showed a mass in the posterior fossa, which happened to be an arachnoid cyst in the vermis, in the cerebellum. And this was a tumor, and after removal of the tumor, it was compressing on the dorsal midbrain, which caused this acute onset of the orthinopalsy. Case 4 is a 30-year-old woman with acute binocular double vision. You can see here, there's an esotropia here, likely a left sixthenopalsy, and there was headache. Face turned to the left, and left esotropia, and left abduction was restricted. Fundus was normal in both eyes. So any sixthenopalsy is considered to be due to tumor, has to be ruled out. You can see here the left sixthenopalsy, and neuroimaging showed a mass, a rounded mass-like lesion. Any round structure in the neuroimaging is potentially an aneurysm, is a blood vessel. You can see here there is a brilliantly enhancing round structure, which is a blood vessel compressing the sixth nerve. So what is close to the sixth nerve, especially in the cavernous sinus, it is an internal carotid artery. So this is a case of an internal carotid artery aneurysm. Because of its close approximation to the internal carotid artery in the cavernous sinus, sixthenopalsy could be caused by an IC aneurysm, and an IC aneurysm is a medical emergency. So in all cases of cranial nopalsies, an MRI and MR angio is mandatory. In a third nopalsy, we have to rule out posterior communicating artery aneurysm. Sixth nopalsy, we need to rule out internal carotid artery aneurysm. The next case is an elderly male, 75-year-old male with sudden vision loss of 2 days duration. The profound vision loss, you can see here, light perception only in one eye. The ESR was very much raised and the CRP was raised. You would have guessed the answer. It is an elderly male. The high ESR and a C-reactive protein. You can see the fundus, profoundly pallid disc edema. You can see the amount of pallor. It's really white, nearly white. You can see some degree of cortical spots elsewhere, suggestive of a profound ischemia. And so this is a case of a arthritic anterior ischemic optic neuropathy, likely due to a giant cell arthritis. Now, why is this an emergency? The reason being that if we don't treat this, the other eye also will get involved. We may not be able to save the vision of this patient, but we have to save the vision of the other eye as well as the life of the patient. So high dose steroids, either oral 100 milligrams or IV methylprednisolone, is useful in preventing attacks in the contralateral eye. Case 5 is a 27-year-old male with sudden decrease in the vision in the left eye of 2 days duration. The best corrected visual acuity in the left eye was 6/60, along with an RAPD in the left eye. Fundus was normal. So in this circumstance, it is tempting to make a diagnosis of retrobulbar bar neuritis. But we should never make a diagnosis of retrobulbar bar neuritis without doing a neuroimaging. He also gave a history of headache and nausea of 2 months duration and vomiting 2 days back. The fields in the right eye showed a temporal hemianopic field effect. So now we have a vision loss in the left eye, and the other eye is showing a temporal hemianopic field effect. You would have guessed the site of lesion. It is in the cella and it is a pituitary mass. Again, similar to the earlier case number 1, which we saw, which pituitary mass with multiple hyperintensities and iso and hypointensities within the tumor, suggestive of pituitary apoplexy. We can see here the tumor is predominantly rising above and it is pressing on the chiasm. So this is an pituitary apoplexy with intralesional bleed mimicking left retrobulbar optic neuropathy. Case 6 is a 35-year-old female with a defective vision right more than left of 2 weeks duration. She had headache for 3 months duration, for which she took a local treatment without having an eye examination. And on examination, she had a finger counting close to face in the right eye, and the left eye showed 6/6. There was an RAPD in the right eye, and the visual fields in the left eye showed a peripheral constriction. So this was a fundus photograph. This shows an obvious papilledema, a very severe papilledema causing an acute vision loss. This is otherwise called as fulminant papilledema. Neuroimaging in that patient was normal, which was suggestive of idiopathic intracranial hypertension with a fulminant papilledema. You can see the features here are multiple cortical spots at the edges of the disc, which are suggestive of profound ischemia. And an emergency treatment for this is an optic nerve sheath decompression, potentially to save the life of the save the vision of the patient. Thank you very much for your kind attention.
Thank you very much, sir, for this lovely presentation and really thought-provoking. I would now request Dr. Bhattu to speak. Dr. Bhattu also has a big list of achievements. And apart from that, I would like to just tell a few things. He's quite approachable, highly knowledgeable, acceptable, and all the abels I can possibly say. And very, very funny also. His sense of humor is very good. And he does it so seriously that we don't know whether we should laugh or just remain silent. I request Dr. Bhattu to talk on the localizing value of clinically. Saujanya, could you share Dr. Bhattu's CV? Yeah, he's the medical director. He was the medical director at Narayan Nethralaya, Bangalore. Presently, he has his own center, Bhattu Eye Center, Bangalore. I request Dr. Bhattu to speak.
Thank you, Kavita. That was very nice of you to say the kind words. I think it's important to have a sense of humor. I think we can start my video. Good afternoon, ladies and gentlemen. At the outset, thank Dr. Kavita for inviting me to participate in this talk, in this symposium. And without further waste of time, let me share my screen with you. The control of eye movements is rather complex. From combining 6 muscles of both the eyes in 2 independent orbits situated 6 centimeters apart in a moving environment with a moving head on a moving shoulder, and coordinating their movements requires an hierarchy of control, which starts with the infranuclear control of the muscles themselves to the nuclei of origin in the brainstem, the internuclear connections between the 2 sides of the orbits, and the supranuclear control of fine movement of the eyes and coordination despite a moving body and a moving environment. Important structures include the interneuronal connection, internuclear connections managed by the MLF, the medial longitudinal fasciculus, which is a long tract starting from the brainstem and going right up to the spine, which joins the 3 ocular motor neurons together. So this is contributed by connections from the vestibulocerebellum and the vestibular nuclei to aid in the fine control of fixation and binocular control despite a very fast moving environment. Internuclear ophthalmoplegia is due to a lesion of this internuclear connection, the medial longitudinal fasciculus. A lesion here marked X connects the left paramedian pontine reticular formation and the left 6th nerve with the right subnucleus of the medial nerve, medial rectus muscle on the opposite side. A lesion here results in an inability to adduct the eye, right eye, while the left eye abducts in an attempted left gaze, and the left eye has a nystagmus. This is classical INO. Whenever you see a patient with an isolated medial rectus weakness or a floating saccade, you are dealing with probably an internuclear ophthalmoplegia, the most common causes being demyelination in the young and vascular lesion in the old. A more extensive lesion of this type is seen when the lesion involves usually a vascular infarct involving the gaze center on the right side, associated with the medial longitudinal fasciculus on the same side, producing a Vanish syndrome called the 1.5 syndrome, where on looking to the right, the patient cannot look to the right. When looking to the left, his medial rectus on this side doesn't act, and he's got complete loss of movement on the right and only half a movement on the left. She had abduction nystagmus, inability to move to the right or the left. So the right eye is practically horizontally frozen. All the other movements are intact. The left eye has got half a movement. And this is a 1.5 syndrome. The Parinod syndrome is related to structures just below in the floor of the 3rd ventricle, in the region of the posterior commissure. The most classical condition that causes this is a pinealoma. And this is because the centers for elevation, the centers for convergence, and the centers of the ocular motor nuclei and the Edinger-Westphal nucleus are all located just subjacent to the floor of the 3rd ventricle. It produces a classical type of nystagmoid co-contraction called the convergence retraction nystagmus because of co-contraction of the superior, inferior, and medial rectus together. It is pathognomonic of a lesion just below the 3rd ventricle. This is called a convergence retraction nystagmus, and once you see it, you'll never forget it. Downbeat nystagmus, again, is fairly localizing to cerebellar lesions, particularly the flocculonodular lobe of the cerebellum. And the most typical structural lesion that causes this is an Arnold-Chiari malformation. Typically occurs when the patient looks down. Downbeat nystagmus is best seen in the extremes of gaze, in the left gaze, as you can see here, and also when the patient looks down. This patient had an Arnold-Chiari malformation, and she had a null point in up gaze. resulting in looking at you with the chin down position all the time. And you can see the downbeat nystagmus. The upbeat nystagmus, on the other hand, has a very large localization of anywhere in the brainstem and diverse etiology. It is not as fairly typical as a downbeat nystagmus, and the upbeat nystagmus persists irrespective of this direction of gaze, and it does not have a null point. Structural lesions, drugs, toxicity, and nutritional factors come into play here. Periodic alternating nystagmus is a very interesting type of nystagmus where there is an alternating right and then followed by a left beat nystagmus in a cycle lasting for between 2 to 4 minutes. Here you see a right beat nystagmus. It dampens, and this is later on followed by a left beat nystagmus. It's important because if you have seen the patient only for 1 or 2 minutes and the patient has a head position, you may plan a head position surgery and be surprised at the outcome, because now you have to deal with the contralateral head positioning, and this never stops. This is treated beautifully with baclofen. You can see the left beat nystagmus now, it is reversed. Brunn's nystagmus is again a highly localizing nystagmus due to a cerebellopontine angle tumor, usually a schwannoma, where on the side of the lesion there is a gaze paretic nystagmus, and on gaze opposite to the lesion he has a gaze evoked nystagmus, which is of small amplitude, high frequency. You can see the gaze paretic nystagmus here and the gaze evoked nystagmus, high frequency, beating to the left, and again the gaze paretic nystagmus on the right side, on the side of the tumor. A very mild skew is also seen in this eye. Ocular bobbing is a very interesting form of ocular motility disorder seen in pontine hemorrhages. Here you can see it looks as if something has dunked his eye in the water and is bobbing up out of the surface of the water. This is seen usually in the emergency room setting in comatose patients because of massive pontine bleed. Opsoclonus is a wild, multidirectional, back-to-back saccadic mania of the eye, so to call. It's called oculomania, and classically seen in children with neuroblastoma, far removed from anywhere in the brain, and it is due to an immune reaction to the tumor, right? It can also be seen in certain syndromes, and immunotherapy works beautifully for this. You can see the immunomania here. You can see the oculomania here. Multidirectional, large saccades. Flutter, on the other hand, is a variation or a milder variation of the same thing, and this is seen in patients probably recovering from a ocular opsoclonus. And you can see a flutter, usually unidirectional, smaller amplitude, higher frequency, and this patient had anti-GQ1B antibodies. Seesaw nystagmus, typically seen in patients with cerebral with paracellular tumors, and if you look at them, you will see the relative skew deviation and an alternating up and down movements of both the eyes, very small amplitude, alternating fast up and down movements. This is called a seesaw nystagmus and usually seen in craniopharyngiomata, etc. Vestibulonuclear nystagmus, when you see a patient with a horizontal nystagmus and you're not sure whether it's due to a peripheral vestibular cause, like for example, a labyrinthitis or a vestibular neuronitis, or due to involvement of the central vestibular nuclei, just remember that peripheral vestibular nystagmus always beats to the same side, irrespective of direction of gaze, whereas central nystagmus beats bidirectionally and is not dampened by fixation, unlike peripheral nystagmus, which is always dampened by fixation. Ocular parietal myoclonus is a distinctive type of nystagmus, which is seen due to lesions involving the connections between these three important nuclei. There are, in addition to the eyes, there are other parts of the body which may show myoclonic reactions. And here you see a patient with a pendular nystagmus, up and down. It could be torsional nystagmus also. And she, opening her mouth, she shows a classical palatal tumor. and this is due to a lesion in the glenoid triangle. Can also be seen in patients with toxicity to various drugs. In summary, I've managed to see some of the most dramatic presentations, show you some of the more dramatic presentations in Neurophthalmic motility disorders, but they all share many etiologies. They can occur alone or in combination, depending upon the area of brainstem cerebellar complex involved. Imaging is mandatory, and very, very important that when the imaging is negative, you need to look and extensively for other causes. Thank you very much for a very patient hearing. And again, at this point, I'd like to thank the organizers once more and my colleagues and my audience for having patiently listened to me. I hope this has been useful.
Ptosis, could you please introduce Dr. Naveen Jayakumar?
Dr. Naveen does not need an introduction. He's probably one of the most celebrated neuro-ophthalmologists in India, and it has been a great honor to know him. As expected, Dr. Jayakumar, Dr. Naveen did not turn down my invitation to give a call, to give a talk, and he was quite open about what he would like to do. And I'm very grateful for his presence here today. As you can see, he's got a wonderful CV, and I'd like to invite Dr. Naveen to the stage. Dr. Naveen, please.
Good morning. I'm Dr. Jayakumar, and I'll be talking to you today about the clinical problem of diplopia, which is something very, very commonly that we see. The first question that I normally ask myself when I see a patient with diplopia is it a monocular diplopia or is it a binocular diplopia? Monocular diplopia meaning when the patient is complaining of that double vision or a slight doubling, even when viewing with each eye separately. In contrast, binocular diplopia is when there's a double vision only when both eyes are open, meaning that the patient is seeing clear single vision when viewing each eye separately. As far as monocular diplopia is concerned, if you think that is the reason, look no further than within the eye, because the problem is there, right from refractive error and dry eye all the way down to macular disease. And I find that quite often many cases of very mild diplopia are due to dry eye and uncorrected refractive error. That visual blur produces it. And so using artificial tears and the pinhole improves it and solves your problem. If you think it's macular disease, sometimes the pinhole makes the vision worse, and think of doing an Amsler test. So that's about monocular diplopia. Now coming to today's talk about binocular diplopia, which is a neuroophthalmic situation, there are several conditions that we need to consider. One is, what is the nature of the diplopia? Which extraocular muscles are weak? Is it an isolated or a multiple cranial neuropathy with involvement of fifth and seventh nerve as well? What about the lids, pupil, and the orbit? And of course, sometimes visual fields are also necessary. As far as the nature of diplopia is concerned, answering these questions helps you to localize which muscle is affected. If a diplopia is worse in a particular gaze, then it is that muscle is weak in that particular gaze. Horizontal or vertical diplopia. If it's horizontal, think about horizontal recti. If it's vertical diplopia, think about the vertical recti or the obliques. Crossed or uncrossed would tell you if it's an exo or an esotropia. And variable and intermittent, of course, points you in the direction of myasthenia gravis. The second is which extraocular muscles are weak. So we try and look for certain patterns of involvement. For example, in this patient who has a right third nerve palsy, there's a ptosis. And as you can see, there's a limitation of adduction. There's a limitation of elevation and depression, but abduction is fine. Okay, so involvement of the LPS, superior rectus, medial rectus, and inferior rectus all put together tells you that she has a third nerve palsy. That's what I mean by pattern recognition. Fourth nerve palsies are a little more difficult, and they propose a challenge in clinical diagnosis. I'm just going to show you one video. You solve this using the Parkes 3-step test. I'm going to show you the third part, which is the Bielkovsky head tilt sign. So here is this child who has a left hypertropia in the primary position. So we are going to use, this is the child in left hypertropia. And you can see we are proceeding with the right head tilt, where you can see that the eyes are almost ortho, looking straight ahead at the camera. Whereas when the child tilts its head to the left side, which you see now, you can see this particular upshoot which is happening. That clearly tells you that this is a left superior oblique palsy. One common problem in a third nerve palsy is finding out whether there's a superior oblique involvement as well. Because when we do ocular motility, we use the depressing function of the superior oblique. So in the adducted position of the eye, does the eye move downwards? And if it does, then the superior oblique works fine. But what happens in a third nerve palsy when the eye cannot adduct? We have to use the other function of the superior oblique, which is intorsion, which is best seen when the eye is in the abducted position. So let me show you this video. This is commonly seen. You can see it every day in your operation theater after blocking the eye for a cataract surgery. And the recti are all blocked, but the oblique doesn't get blocked that easily. And you can see this intorting effect. Here you go. Take a look at these conjunctival vessels on top. You can see they rotate well. You can see the eyeball is turning inwards. And that clearly indicates that this is the superior. This is the kind of movement I want you to look for in a third nerve palsy, which will tell you whether the superior oblique is working or not. Multiple cranial neuropathies are important. There are several life-threatening conditions which can produce this. This is a lady who had a right-sided ptosis with absence of adduction. The abduction seems almost full, very mild limitation, very subtle. Depression is 0 and elevation likewise is 0. So this is a pupil-involved third nerve palsy which she had, and we want to know whether the fourth nerve is involved as well. So in the abducted position, I'm asking her to look from up to down to check whether the right eye is intorting, which it isn't. You can see that there's no movement at all on the right side. One thing about the abduction that I spoke to you about earlier, you could see that the movement was almost full, but look at the speed of that movement and see how slow that is. Compare that to the left eye, which adducts in a flash on right gaze. The right eye takes its own time, and you can see that very well. I slow down the video and you can see the left eye has already reached its adducted position and the right eye is still moving very, very gradually. A slowed saccade is important as an indicator of subtle sixth nerve weakness in this particular patient. She had a huge right cavernous sinus space occupying lesion, which on an MR angiogram turned out to be a large internal carotid artery aneurysm. Moving on to lids, pupil, and the orbit. As far as the pupil is concerned, think of anisocoria, something that is a must, unequal pupil size. One small tip which my teacher taught me is, which is the abnormal pupil? Is it the smaller one or the larger one? And he said, just do a direct light reflex. And in general, if a pupil is not reacting well to direct light reflex, it's a little sluggish, it is the abnormal pupil, whether it is a little more dilated or a little more constricted. So that's a little bit of a tip for you. As far as lid movements are concerned, ptosis is a feature of third nerve palsy, but remember, mild ptosis is a feature of Horner syndrome. And lid retraction, of course, you see in thyroid disease. This patient's image is interesting because it looks as if he's got a lid retraction here and a prominent left eye. Whereas actually, if you look at the pupil size, it is the right pupil which is slightly smaller than the left. This is an anisocoria, and you can see a very subtle ptosis. Compare this lid with the other side. And what is interesting is the lower lid position that you see here. You can see the lower lid position here, and you can see kind of an upside down ptosis with the lower lid margin moving up a little bit. So the presence of a myotic pupil, a little bit of a mild ptosis, apparent enophthalmos, this patient has a right Horner syndrome. Okay. Lid and pupil gaze dyskinesias are not uncommon in third nerve palsies, but remember that they are never due to ischemic third nerve palsies. If you made a diagnosis of ischemic third nerve palsy and you see aberrant regeneration subsequently, revise your diagnosis, do a neuroimaging. It is mandatory because it could reveal either trauma or it could be a space occupying lesion. Now, in this particular video, patient with third nerve palsy, so the examiner has lifted the ptotic lid, the left eye, and is doing the ocular motility. As you can see here, elevation and depression are restricted. But watch what happens because of this. So let's leave that lid alone and just see what happens when the patient looks from up to down. See the position of the left lid. And you can see that it jumps up suddenly when she looks down. There you go. Okay. So this is an example of an aberrant regeneration between the inferior rectus and the levator, where you get a retraction. Here you see it again. You can also see the regeneration aberrantly between the medial rectus and the levator. So you can see a retraction on adduction here. Here you go. Okay. So this is an example of lid gaze dyskinesia. We also have pupil gaze dyskinesia. This was a patient who had a traumatic left third nerve palsy. And you can see the right pupil is normal in size. The left pupil is clearly mid-dilated. But watch the difference in pupil size in the abducted position of the left eye and the adducted position, where it's a lot smaller. There's some action of the sphincter because of aberrant regeneration connections with the medial rectus. So this is an example of pupil gaze dyskinesia. Okay. Always remember myasthenia, last but not the least, it's a great mimic. I just want to quickly run through some of the lid signs. Clearly, if you ask the patient to look up, you'll get an increasing ptosis, okay, because of fatigue on sustained up gaze. You can see the eyes slowly drooping down, and the patient is elevating his chin also in order to see clearly. The second thing is you have something known as a seesaw ptosis. If you lift up the right lid, the left one droops. Conversely, if you lift up the left lid, the right one droops further. The third is the Cogan's lid twitch sign, where if you look down and then ask the patient look straight, you get a little jump of the lid before it settles down again. The simplest test for myasthenia gravis, which you can do in the room itself, is the ice test for ptosis. So this is a patient who had a left-sided ptosis, which you can see here. We used an ice water bottle because we didn't have ice that day in the clinic. This was in China. Yes. And you can see after this 2 minutes of putting the ice, you can clearly see that the ptosis has disappeared. Okay, so this diagnosis is myasthenia gravis for sure. Okay, couple of last two slides. What about patients with binocular diplopia, but the eye movement appears to be full? So think about recheck for monocular diplopia. It could be a subtle cranial nerve palsy, especially fourth nerve palsies do this. Variable and intermittent diplopia in myasthenia can be an issue, or sometimes it may be a phoria breaking down to atropia in a concomitant squint. Less commonly, we have hemifield slide phenomenon in bitemporal hemipituitary tumors, which is why I said do the visual field, and sometimes they can have double vision as well. Skew deviation, a dragged fovea syndrome, and functional causes are also there. I'll quickly jump to my last slide, which is dangerous diplopias, where you really need life-threatening issues. So if you have a pupil-involved third nerve palsy, it could be an aneurysm. If you have painful ophthalmoplegia with orbit signs, think of Toulouse-Hunt syndrome and mucormycosis. Multiple cranial neuropathies, problems will be in the orbit or cavernous sinus, but also in the skull base as well. Problem with more than one of these, with the lid or the pupil or eye movement, for example, ptosis with a small pupil is a Horner syndrome. Ptosis with a larger pupil could be an aneurysm, or it could be a Guillain-Barré or Miller-Fisher variant of the Guillain-Barré syndrome. Variable diplopia with generalized weakness and fatigue, myasthenia. Remember, these patients are at risk of going into myasthenic crisis, which is dangerous to life. And of course, new onset headaches, not only aneurysms, but if they are associated with scalp tenderness and pain on chewing in the elderly, temporal arthritis, keep that in mind. With that, I conclude my talk. Thank you all for your attention, and have a great meeting.
Thank you very much, sir. Ravindra Pattu, sir.
Dr. Naveen, I thank you very much for the absolutely brilliant and therefore what appears to be on the surface a very simple talk, but it takes a lot of experience to make it so simple. Thank you once again. Dr. Kavita, are we on for some questions now, or would you like to take the questions later?
Maybe we could finish off with the questions, sir.
Do you have any questions coming in from the audience?
This is about traumatic optic neuropathy. Question is, what are the early signs so that we can start IV methylpred?
To whom is this question directed?
I think we will direct it to Dr. Mahesh.
Thank you. So traumatic optic neuropathy is detected by the external clinical signs like lid laceration in the upper eyebrow region in the lateral 1/3, a subconjunctival hemorrhage maybe, and most important finding is the relative afferent pupillary defect. Remember, the fundus will be normal at the time of injury because the pallor will take 3 weeks to set in, because in the indirect traumatic optic neuropathy, the site of injury is at the intracanalicular level, where it is tightly held in a compartment syndrome. And any injury there, for the atrophy to descend into the optic nerve head, it will take about 3 weeks. So at the time of presentation, it's a normal fundus, and relative afferent pupillary defect is the most important sign. But also remember that in the crash study said that severe head injuries can IV methylprednisolone high dose steroids can be life-threatening. So it should not be given. So it is not it's not a definitive treatment IV steroids. It has to be given judiciously, and it is perfectly okay not to give high dose IV steroids if there is a severe skull base injury, especially with CSF rhinorrhea and other findings. Thank you.
Thank you, sir. Thank you so much. And regarding diplopia, I would like to ask Naveen sir, what are the common errors done in assessing a patient with diplopia? As a beginner or a postgraduate or a fellow, could you please?
I think
the common errors.
Yeah, the main one, quite often, actually, not uncommonly, I get patients referred to me who actually have monocular diplopia, and that's why I put that right at the beginning. That just differentiate if just do that monocular versus binocular test, and if it's monocular, just look inside the eye. The problem is there, and if it's binocular, then you can refer it to a neuro-ophthalmologist if you doubt it. I think that very simple test will solve half the problems with patients who have the slight blur, etc. Okay. The other thing is, of course, the biggest difficulty, I think, third nerves and all are easy. The only thing I would tell people to look is be careful when you assess in third nerve palsy. Look for the pupil signs, subtle anisocorias, little deficiency in light reflex. So it becomes really critical to look at the pupil in a third nerve. The third thing I would say is fourth nerve palsies are very difficult to assess, and you can take the help of a neuro-ophthalmologist, but just ask. Dr. Lawton Smith used to say, just ask one question. If it's a vertical diplopia, which is the eye with the lower image, and that's most likely to be a fourth nerve palsy in that eye, and then you just do the Bielkovsky and figure that out. I think it's very unusual to have not a fourth nerve palsy. There are other conditions, obviously, like thyroid, etc., will also cause. But fourth nerve, I think just look for vertical, do the Bielkovsky, that's enough. And a simple red-green test would tell you which eye is up, which image is higher, which image is lower. And myasthenia, my goodness, myasthenia, you just have to just keep a watch on it. It's very easy if there is a ptosis, because you can do the ICE test and confirm it. But if there is no ptosis and only diplopia, then it becomes a little more challenging.
Yes, I agree with myasthenia as well as the fourth nerve. I think one other finding which I would like to share is in our patients, what I have seen is even if the extraocular movements are full and everything seems normal, that's how when the fellows or students, they refer to us. I feel one simple question of asking whether they are feeling uncomfortable. Yes. Sometimes may not be even diplopia, because some of the patients, they don't know how to appreciate diplopia. And diplopia is actually confused even with blurred vision. Even they might be having refractive error, or patients with diabetic status, which is blood sugars are very high. They also complain about double vision or blurred vision. They may not have really a neurophthal lesion or neurophthal finding. Is whether they are uncomfortable walking down the stairs is something which quite often we have elicited. Absolutely. They may not tell, sir, but when we ask them specifically, probably they appreciate that while walking down, they are
history that you can ask. Yes,
very, very uncomfortable walking down the stairs, which they have noticed probably in a couple of days. Sure. So that is one thing which we have picked up. And as you say, myasthenia, I think in my experience, whatever I cannot diagnose, I just think I get a doubt, maybe it is myasthenia. because patient is very uncomfortable with the symptoms that they're experiencing. And invariably, when I send it for a hydrophonium test, it comes out positive.
Yeah. One thing is, I think these patients, it's worthwhile repeating the ocular motility on another day, because you get sometimes very varied. I remember long ago in Nethralaya, when I was just starting, there was a patient who was referred for, who would come up, seen 3 months earlier and referred for squint surgery and come for squint surgery. So when I checked him initially, it worked. And by the time I wrote down the case report and turned back and rechecked to see which one was affected, it had changed. And literally that sort of made us work. But one important thing about the nature of the double vision, the second image in binocular diplopia, if it is due to a neurological cause, the second image is always a slightly out of focus, blurred image. It cannot be clear. If a patient is saying both images are absolutely clear, they're most probably malingering.
Correct. That is probably the last thing we have to tell, malingering.
Yeah.
And other thing that I have analyzed is whether they are supranuclear lesions. There is some pathology there. Then they have this weird, everything looks normal, but then they complain of diplopia. Is one thing which I find is supranuclear lesions.
Okay.
So then I refer to a neurologist.
Right.
Invariably, it turns out something there.
Sure.
Could I contribute?
Yeah, sure.
Yes, sir.
Yeah, but
2 points of note. Very carefully done cover test in the down gaze position may elicit, you may be able to elicit a subtle fourth nerve by just looking at the movement of the eyelids. You may not even see the movement of the eye. You'll see a movement of the eyelid. And, 1 to 1.5 diopter of misalignment is sometimes picked up. And second point is the most common extraocular movement disorder not being diagnosed by a neurologist is the fourth. They will diagnose the sixth and the third, but they will never diagnose the fourth.
Very difficult. Yes, sir. Thank you. Thank you so much.
I have a question on diplopia.
Yes,
so to Dr. Naveen, especially for the sake of postgraduates, supranuclear pulses is traditionally taught as more diplopia. And how do we explain the double vision which occasionally occurs in supranuclear palsies?
I wouldn't be too. Most of the time, I generally stick to the aphorism. I think most of the time it fits in that supranuclear, you won't get diplopia because the eyes are equally affected. Unless, I don't know, Mahesh, what do you think? I'm not too sure.
Yeah.
Unless you think there's aphoria or some other underlying.
I was imagining whether most of these have associated skew deviations. Is it possible?
It's possible, Mahesh.
I'm not sure.
Mahesh, the other important thing we miss out in many of these patients with progressive symmetrical ophthalmoplegias is the fact that many times your eyes are not converged enough to the target.
Okay. Okay, sir.
So many times it retains parallelism even when you present an object at 1 meter and his eyes are parallel and he's not converging. He sees the double vision despite an apparently symmetrical loss of movement. So this can be it may mislead you a little bit.
I would assume there may be slight asymmetries in the thing. I mean,
correct. I agree.
So mild that we don't.
It's not impossible to be.
Yes, but you can
absolutely very mild asymmetries might be existing.
Okay.
Yes. Yes.
Thank you.
How about Fresnel prisms, sir? Can you give some tips in prescribing Fresnel prisms in diplopia? When exactly you would suggest?
Actually, I hardly ever use Fresnel prisms nowadays. To be very practically, I can confess that they're quite expensive, and most of my patients, I would think of. We used to give Fresnels in diabetic third nerve palsies when they're improving, and they're very fussy patients who want to see single. That was abroad, but in India, I hardly ever use these Fresnel prisms. I think sometimes I find them a little more useful if you're dealing with, say, thyroid ophthalmopathy and a diplopia. That makes a little more sense to me than things. So I usually ask patients to occlude their eye if they're having like a diabetic third nerve or something like that, because it gets better very fast. Yes. Yeah, I don't know, Mahesh, but any comments on that? Do you use Fresnels a lot? Or?
No, we use Fresnels only for field effects here.
There you go.
That's it.
It's quite
I use
expensive.
Fresnels for subtle
It's,
palsies. One thing about using Fresnels is that you cannot use it for very gross abnormalities in ocular motor function.
Yes.
You probably want it to expand a little field a little bit. And and if there is a very severe incompetence, then you're likely to have a little problem with using Fresnels. Now, another very place where I have used low power Fresnels is a patient who has got fourth nerve palsy with purely a vertical, has gone into competency, has got up and down defect without much torsional effect, and it requires a little more than 5 or 6 PD of prism in the glasses, which makes it difficult for him to handle those thick glasses. Fresnel usually solves this problem. So there have been occasional situations where a Fresnel has helped me. But again, small motilities, defects, and 2, no gross incompetence. That would be an area where the Fresnel would be useful.
And also, it's a little bit of a trade-off with the patient between taking care of curing the diplopia, but also accepting a little bit of visual degradation in the quality of the image.
Absolutely.
It just produces a little bit.
No, it's a trade-off.
Look through a Fresnel, you'll know how
it's a trade-off.
Yeah, it's a trade-off.
Then, sir, Bhattu sir, you have any questions? Should we go to the...
one comment about traumatic optic neuropathy. Dr. Mahesh, 30 years into treating patients with traumatic optic neuropathy has convinced me that patients with traumatic optic neuropathy should not be visiting doctors. They should be visiting temples, because only God can restore it, number one. Okay. and number two, you always do a perimetry on the other side, because
whenever possible.
In a patient with a traumatic optic neuropathy, more often, many times we have seen junctional scotoma because of the severity of the injury causing a chiasmatic defect. And there is an important question, because the question is, can this fellow ever drive again in his life and avoid killing other people? The junctional scotoma tells me that he should not be driving again in his life. A monocular injury says if he's got 20 years of experience driving, he can still drive. But a junctional scotoma, no more driving. It's too dangerous for him to drive.
Thank you, sir.
Thank you, sir.
The one question to Dr. Mahesh is, any unusual experience which you have had, which taught you what to do and what not to do in ocular neuro emergencies? Anything that is that you remember so well and vividly?
So there are 1 or 2 experiences which we have had in the outpatient department. So what I would like to tell is, any patient who's acutely coming with clasping his head and coming to us a new onset of headache from the morning, from today morning or something like that, then at least 2 instances we have had. We did an emergency CT scan. We need to rush them to the CT scan center, and we detected subarachnoid hemorrhage. So an acute, really painful headache, which is new onset, 1 hour, 2 hours, and the patient is really clasping his, holding his head. Please treat it as an emergency, and somebody has to go with the patient to do the neuroimaging so that there is no delay there. So that is something I would like to I remember all this. And another one is pituitary apoplexy. We have had one patient who was being examined in the outpatient and suddenly collapsed, and all emergencies CT, not MRI, because CT is quick to get. And that's how we detected one case of apoplexy. Those are 2 things I always remember. Thank you.
Yeah,
Thank you so much, sir.
I would probably add, just don't expect every case, just because you saw them in the past, to have exactly the same problem. I remember, I think Dr. Lingam Gopal, when I was there, we had a patient who had a history of thyroid ophthalmopathy with an acute proptosis presenting severely. So with oral steroids, he got better, really well improved. But 6 months later, again, he presented with another acute attack of proptosis. You're treating with steroids, and progressively it was getting worse over 2 days, and the vision actually dropped from 6/9 to counting fingers or something like that. At that time, we were wondering what's going on, and we re-imaged the patient at that time and found he had an orbital cellulitis and an abscess. completely unrelated. So which would have been exactly the opposite treatment to systemic steroids.
Similar experience we also had, sir, in a child actually. They came with history of severe headache. Sometimes, the parents tell, maybe it's just before exams and things like that. So the child is, malingering or what. But then we sent for neuroimaging. We picked up a tumor in the child. So like even in children, we tend to think malingering.
That's true. The other problem, I think, many of you may, all of us face, I think we are also seeing a lot of general ophthalmology patients in between the neuroophthalmology. I don't know how it's with you, Mahesh, but everything gets mixed and comes. So in between all your refractive errors and those vague headaches comes a headache, which is not really a refractive headache or a general thing. And we need to be constantly on our guard for this. I remember one patient who had this kind of unexplained headache, young girl, around 20s, in her 20s, who was quite fine when I examined her at 4 o'clock, but she said it was quite a severe headache and unusual. I said, go get an imaging done. So she went the next morning to get an imaging. And then I heard, because it was someone known to some person in the hospital. So I said, what happened to her? Apparently she'd gone to for the scan and then dropped dead there. Oh. So probably some kind of an aneurysm which burst or whatever it is. So I think like what Mahesh said, sometimes you literally have to send someone with the patient and get it done. It's very easy in a big hospital to say, ask someone to do this, and the other. But I think you need to physically sometimes just stop everything else and focus on this one person who really needs your assistance at that time to get things moving. There's red tape everywhere. So even in our place. So I think one needs to sometimes be very proactive about this, and it pays off.
Yeah, I agree.
And usually happens on Saturday evenings.
Yes.
Yes, sir. The more you want to go back home.
Kavita,
yes,
I think we are running a little late.
Yes, sir.
And I'm dying to introduce you.
No. I told you, you're very funny. Sense of humor.
Yeah. So, Dr. Kavita, I met her first time in Shimoga when I had gone there to participate in a Neuro of that symposium. And it was very kind of her to remember me when she was put in charge of organizing the symposium. As you can see, while she's banding her word humble around, she's one of the most humble people I have had the pleasure of meeting. And being humble, she said, I'm probably going to take a very simple subject. Dr. Kavita, I'm sure you'll do great justice to that. Let's proceed with your talk.
Thank you, sir. Morning, one and all. At the outset, I would like to thank COSCON for giving me an opportunity to talk on localizing value of visual field in neuroophthalmology. I have no financial interest in this presentation. Visual field, as we know, is an important tool in evaluating lesions involving the visual pathway. It is performed at baseline and periodically during follow-up for diagnosis purpose, prognosis, and in neuroophthalmic cases for rehabilitation strategies. Choice of perimetry, there is no clear guidelines for neuroophthalmic disorders. We would like to use a standard automated perimetry, and the most commonly used is 30-2 program. 1 to 2% of peripheral abnormalities beyond 30 degrees in the absence of a central visual field defect. CETA is another program which is a reliable alternative to Goldman perimetry in children. And the second generation frequency doubling technology helps in evaluating the optic nerve and chiasmal disorders. However, Goldman perimetry is very useful in severe visual and neurological deficits or in patients with isolated peripheral visual field defects. We have to remember this point. Yet another technique or assessment of visual field is the confrontation technique, our old age method. It is a critical part of the examination, even in patients who also receive formal visual field testing. Why I'm saying this is that you could have a field defect as is seen right side, which is a constricted field severely, but you could obtain a confrontation field which is normal, then one should think that these deficits or defects which are seen on the visual field represents an artifact, not a pathology. It might be better in this case to repeat the field or use Goldman perimetry. Let us look at the prerequisites. Patient should be able to comprehend the test. That means higher mental function should be good and age should be appropriate. Patient should not have associated neurological motor deficit so that it does not hinder from performing the visual field test. Vision should be able such that the patient should be able to identify the light stimulus in the field analyzer. In case of doubt, better to take the patient to the field analyzer and ask him or her whether they can see the illuminated light or dot. Color vision deficient, we can still do the test. This illustration is a standard illustration which all of us know, and it is a very handy guide in case of doubts. Let us look at the visual field chart. First, in the right upper corner is the patient's details. We have to look into it carefully, and also look at the laterality, which another point is that look at the blind spot and then we can get the clue on the which side it is. Usually whatever field you're seeing, the right, or the blind spot, you can identify it in the opposite side. Then visual field reliability details, you look at it, whether they are reliable, whether the field effect is respecting vertical meridian. Most of the neurological disorders have a vertical meridian pattern. As I said, blind spot, you look at it, so that gives a clue to the laterality. And pattern deviation, plot for detection of the defect, and grayscale is easier to understand and explain to patients. However, most important is that both the eyes' visual field should be analyzed. Now let us look at some few important case scenarios. As you can see, there's a field defect in the grayscale as well as in the pattern deviation in the upper part of the plot. So we will think that is a sort of a hemifield or a arcade defect. And the same patient had a optic nerve head which looks slightly elevated at the inferior part. And this could be an altitudinal field defect. These are exceptions where you get horizontal field defects. But before going in for pathology, always rule out physiological causes of optic disc elevation. One common finding which we pick up in clinical setup is drusen, which can be easily identified by ultrasound B scan. This is a field defect or generalized field defect 1. It's on the left side. And you can see on the MRI, there is a hyperintense lesion involving the optic nerve. Probably it could be optic nerve glioma. As you can see in this line diagram, there is a lesion at the optic chiasma. So what kind of field defect can we expect? So because the nasal fibers are crossing, we can expect that the temporal field defect on both the eyes is getting affected. It is heterogeneous hemianopia, but is not on the same side or one side. So clinically, we should think of pituitary tumor and craniopharyngeal, any midline tumor near the pituitary organ. So this is the neuroimaging. Get the neuroimaging done. You can find some lesion here. We could take an opinion from the radiologist. Same thing in sagittal section. You can see a lesion here, hyperintense lesion, probably pituitary microadenoma. Now let's take a look at this field. If there is a field effect on one side and something like this in the superior temporal area, then probably we should get a clue that it is affecting one optic nerve at the junction of optic nerve and chiasma. This is the area where you have the other eye nasal fibers crossing over. So you could have a junctional scotoma. What is important clinically is this. In sometimes when you do the 30-2 field, the superior temporal field defect which you're seeing on the left can be missed. So if there is a field defect in one eye or clinically some problem is there in one eye, you have to look for the other eye field carefully. Or you need to follow these patients regularly by doing fields and even examining the optic nerve. Likewise, can we have binasal field defect? Yes, of course, we can have binasal field defect, although I'm not seeing so commonly. Few conditions which can give rise to is optic nerve head drusen itself is a physiological condition. Ischemic optic neuropathy, optic nerve pits, hydrocephalus, and aneurysm of intracranial and ICA, internal carotid artery. So neuroimaging helps definitely. Now look at this field. There is this left half of the field which is blackened up. Likewise, this is nasal field defect on the right eye. So obviously this is left-sided homonymous hemianopia because it's on the same side. Where could be the lesion? So this is on the right side, and a lesion could be in the optic tract. So here you can see some hyperintense area, or something like a triangular band involving the uncus of temporal lobe and optic tract. Look at this picture. Only one quadrant enopia. Yes, quadrant enopia. It's on the left side of the field in both the eyes. So this is the pie in the sky, which is typically or classically described as pie in the sky. We could have lesion in the right side. So right side, where could it be? It is in the temporal lobe. So there is a hematoma here, hyperintense area, which is picked up on neuroimaging. So finally, we have to do neuroimaging for any lesion that we pick up clinically here. One is fundus finding and second is the field. So similarly, if you have a quadrant anopia, which is at the inferior aspect, this is a left inferior quadrant anopia. This is pie on the floor. So the lesion will be in the right parietal lobe. Now coming to the last area of the visual pathway, you can see that in this field, there is the right-sided field defect, but at the central area, there is sparing. So obviously this is right homonymous hemianopia with macular sparing. This macular sparing, as all of us know, it's because of the dual blood supply that this area in the visual cortex that it receives from middle cerebral artery and posterior cerebral artery. So this is the left occipital lobe tumor. What are the advantages of visual field in neuroophthalmic disorders? As I mentioned earlier, it helps in localizing the lesion. It helps us to correlate clinically. It's also has a lot of value in prognosis. And most importantly, it helps us to rehabilitate these patients because they have some kind of field defect. It helps us to understand what kind of devices we have to give and how they should go about in their day-to-day activities. That is the most important. We know that this lesion, this clinical finding can have this field defect. So, but what next is the question. We need to understand how to rehabilitate this patient, how to counsel this patient, how they should carry about their day-to-day activities. And for example, driving or looking at the television or computer, how they should go about. This is what is most important. However, visual fields does have its own limitation. For example, if false positives are high or false negatives are high in the visual field chart, then we need to do first thing is to repeat the fields and probably, order for another kind of field or any other test which will support us clinically to our clinical findings. It's a subjective test, so it depends on the patient. So we have to analyze what kind of patient we are asking them to do the fields. Extreme peripheral defects cannot be picked up, so we use Goldman peripheral. To conclude, visual field should be carried out in all neuroophthalmic disorders. In unilateral optic neuropathy, visual field of the other eye is important and to follow up. Combination of visual fields are useful in some situation. It should be correlated with clinical findings and neuroimaging, and if possible, even orbital ultrasound. It is significant effect on quality of life and mandatory in the rehabilitation process. Thus, visual field helps in diagnosis, prognosis, and rehabilitation. Thank you.
Dr. Kavita, thank you very much. That was a very nice talk. And as suggested by you, we have a lot of questions to you and a lot of discussion on this. Quite exciting field. Visual fields is a quite exciting field. But not to do injustice to our guest speakers who have been specially invited for their expertise, would you like to introduce Dr. Srinivasan?
Yes, sir. Dr. Srinivasan is a radiologist at the KGS Center, Madurai. This Srinivasan sir also was suggested to me by my students here. And apparently I heard he is a man of academics. And probably after going through this short CV of his, I felt he's a walking encyclopedia. Apart from that, the 2 points that I gathered is that in case we miss on writing some findings or the diagnostic technical terms which we want, Dr. Srinivasan himself, after having seen the findings in the neuroimaging, he advises or goes about doing the extra additional investigations which require, so that he can arrive at a proper diagnosis. This is something which he does on his own. The second thing is he explains so well to the fellows and students whatever doubt they have, that is so approachable. On the other hand, that I wanted to tell, and he suggests what has to be looked into the patient's clinical findings. So it makes us come back and have a look at the patient again. So we would have missed something, but he on the imaging findings can tell without seeing the patient. This is what I want to tell about Dr. KG Srinivasan.
Morning, everybody. I wish to express my sincere thanks to Dr. Kavita to give me this opportunity. And this lecture is for about 12 to 15 minutes. And I wish to thank Aravind Eye Care System. Because of them only, this much amount of voluminous material available for this lecture. Let us start with the cases. This patient presented with the left side 6th nerve palsy of 3 months duration. And you can see typical 6th nerve palsy, and this is non-enhanced CT sections. If you are carefully seeing, this is right orbit, optic nerve here, this is medial rectus, and this is lateral rectus. And here medial rectus is visualized. Here the lateral rectus is grossly thinned out, suggesting denervation, atrophy of LR muscle. And medial deviation of left globe noticed. All these findings suggestive of 6th nerve palsy, but we are not able to identify anything in the region of cellular, supracellular, or paracellular region. The next section, if I am going down, you can able to appreciate there is a destructive lesion in the posterior aspect of clivus. And if we are going back and screening the chest, we can able to appreciate there is a bronchogenic carcinoma. And this is the secondary deposits in clivus, where this is the course of 6th nerve from pons to Dorillos canal, where it is completely engulfed by the secondary deposit responsible for 6th nerve palsy. So it is a bronchogenic carcinoma with the clival secondaries and the left 6th nerve palsy. This young patient presented with cortical blindness. This is post-contrast CT. You can able to appreciate large metastatic lesions. You can able to see the hyperdense, brilliantly enhancing lesions in both occipital lobes. And this is responsible for cortical blindness. Going back and asking the history, this patient had treatment for osteosarcoma of the right mid-femur, and screening of the chest showing extensive cannonball metastatic in the lung, and we can appreciate occipital lobe secondaries responsible for cortical blindness in this patient. This is third patient presenting with the painful ophthalmoplegia on right side. This is imaging post-contrast MR. There is brilliantly enhancing soft tissue lesion involving anterior cavernous sinus, orbital apex, and SOF. And you can see the brilliantly enhancing lesion in the coronal images also. And this is the normal orbital apex for cavernous sinus. This is the mass within the cavernous sinus and orbital apex. And the arterial system in circle of Willis is absolutely normal. So it's a case of inflammatory lesion at right orbital apex anterior cavernous sinus region, SOF, responsible for painful ophthalmoplegia. It is Flos-Ahern syndrome. Most probably the diagnosis is idiopathic pseudotumors. This patient presenting with the primary optic atrophy on both sides. This is fourth case, and you can see the fundus pictures. And this is the scanogram. Whenever you are seeing scanogram, few important structures you should look. This is planum spinodale, and this is anterior clinite process, anterior wall of cellar, and this is the floor of cella, posterior wall of cella, posterior clinite process, and this is the clivus. And here it is absolutely normal. We may not able to pick up anything. So CT was ordered. CTS, this is the NECT images. This also, unless we are carefully seeing, we may not able to pick up this such a large isodense mass in NECT. And after giving contrast, you can able to appreciate brilliantly enhancing with the contrast, homogeneous enhancement. And this is the pituitary fossa diaphragm ocelli, and this is the pituitary fossa. The lesion is situated above the pituitary fossa, so this is a supracellular mass, and pituitary gland absolutely normal. And this is the sagittal sections. We can able to appreciate there is a mass in supracellular planum spinodale location, and this is the classical location of the mass. Pituitary fossa is absolutely normal, and the pituitary gland is normal. So it is not of pituitary origin, it is a supracellular origin. And a few important findings will help. If you are seeing the bone, here it is hyperostosis. That means a rich vascularity producing neovascularization induced hyperostosis of the bone, and you can see the sphenoid sinus is hypopneumatized. So these two important findings plus extraaxial lesion, planum spinodal location, it's a case of supracellular planum spinodal meningioma. So meningioma will be supracellular planum spinodal, and it will produce dural tail sign, and it will produce hyperostosis of the adjacent bone and hypopneumatization of the sphenoid sinus, so-called pneumosinus dilatans. And it is supracellular planum spinodal meningioma responsible for optic asthma compression with bilateral primary optic atrophy. This is next case presenting with bitemporal hemianopia with primary optic atrophy, and this is the scanogram. There we have seen beautifully the cella. Here you can see the double flooring of the cella. You can see the one floor, this is another floor, and the pituitary fossa is enlarged. You can see the enlarged pituitary fossa, and here rarefication of the anterior clinite process, posterior clinite process is not visualized, and rarefication of the posterior wall of clivus is also there. So this here, the expanded pituitary fossa, that means the lesion is coming from pituitary gland. This is the CT sections, beautifully demonstrating figure of 8 configuration of the lesion. You can see the cellular supracellular figure of 8 configuration. Here, the cellular component, this is the supracellular component of the mass is there. And this is MR image beautifully demonstrating the pituitary macroadenoma from cellular supracellular location with the compression of the optic chiasm responsible for the bitemporal hemianopia. In this case, this is pituitary macroadenoma. Sometimes pituitary adenomas can present with apoplexy and present as neural deficits. This is a case pituitary macroadenoma with apoplexy. How we can identify apoplexy? Since it is having blood products, they will become bright signals in T1 weighted images. This is because of methemoglobin blood products. It's a typical case of pituitary macroadenoma with apoplexy. And how to differentiate pituitary macroadenoma from meningioma? This is simple rule. Always look for size. You can see the normal pituitary fossa, and the tumor is predominantly supracellular location, and hypopneumatization of the sphenoid sinus, and hyperostosis of the planum spinodale and supracellular locations. All these things are very classically seen with the meningioma, supracellular planum spinodale meningioma. And if we are seeing in this case, this is pituitary fossa is grossly enlarged. It is a cellular supracellular mass, figure of 8 configuration, no hyperostosis, nothing is there. So it's a typical case of pituitary macroadenoma. These are the points we can differentiate pituitary macroadenoma from meningioma. And if the child is presenting with vision loss, how we can look into it? Here, this is a supracellular mass. There is a supracellular mass is there, and supracellular mass showing mixed signals, and the classical location of optic chiasmic hypothalamic involvement. It's a case of hypothalamic optic chiasmic glioma responsible for visual loss in this child. And the choline peak is very classical in this case, and a significant reduction of NAA as well as CR. And this MR spectroscopy will confidently we can tell this is the diagnosis case of supracellular optico-chiasmic hypothalamic glioma in this case. This patient, elderly individual, presenting with right side Turner palsy, pupil involving Turner palsy, with coexisting 4th, 5th, 6th cranial involvement. You can see the ptosis over right side, and you can see the dilated pupil. Pupil involvement is there, and you can see the extraocular movements are also totally restricted. And the MRI beautifully demonstrating there is a thrombosed cavernous IC aneurysm with various, you can see the various stages of thrombosis, and the patent lumen is only this much, and this large area of thrombosis on this region. So it's a case of a thrombosed cavernous IC aneurysm responsible for 3rd, 4th, 5th, 6th cranial palsy, with the pupil involving 3rd palsy on right side. This patient presented with optic neuritis. This is the fundus pictures. Whenever optic neuritis is referenced, sir, it is our responsibility to rule out multiple sclerosis or neuromyelitis optica or MOG antibody-related demyelination disorders. If we are screening, you should screen entire brain orbit as well as entire spinal cord should be evaluated thoroughly in these patients. And this patient brain, this is the normal target sign of left, and you can see this on right side. And you can able to appreciate the brain lesions. This is classical marginally enhancing. The pile surface will get enhanced. This opposite side will not get enhanced. This is typical appearance of a broken ring or semi-garland appearance of the enhancing pattern. And here you can see the spinal cord involvement. This is also another classical location where we will get the spinal cord involvement of multiple sclerosis. So it's a case of multiple sclerosis with involvement of optic nerve in the form of irritable bowel neuritis with the brain demyelinating lesions. And this young 12th standard student presented with internuclear ophthalmoplegia and presenting as vision loss as well as ophthalmoplegia. If you are carefully seeing, this is a normal optic nerve. Normal optic nerve will have target-like appearance. The central low signal is due to optic nerve, and the surrounding bright signal is because of perioptic subarachnoid space. And if it is affected, this is absence of normal target sign. That means it is irritable bowel neuritis. The nerve is inflamed. And this patient, apart from right side irritable bowel neuritis, there is a bright signal lesion in the location of medial longitudinal fasciculus. That means the child is suffering from irritable bowel neuritis as well as involvement of MLF is also there. Then the screening of the rest of the sites. You can see there are lesions in the corpus callosum and pericallosal region giving classical Dawson's fingers-like appearance. And periventricular lesions are showing moderate ring or broken ring enhancement is there. So all these things together, it's a typical case of proved multiple sclerosis, and the CSF analysis is also done. It's a case of proved multiple sclerosis. The presentation is a right side irritable bowel neuritis and ophthalmoplegia of internuclear type. It is the presentation. This is another case presenting as post-traumatic optic neuropathy. Whenever post-traumatic optic neuropathy, our evaluation should be CT as well as MRI. CT to look for small fractures. This is normal anatomy. You can able to see the anterior clinoid process. There are bony projections will come from anterior clinoid process. This is called optic stroke. Optic stroke, medial lateral optic stroke. Here you can able to see the optic canal. Here you can able to appreciate on left side there is a fracture in the floor of optic canal, and MR beautifully demonstrating the contusion of the intracanalicular segment of optic nerve, and it is more bright. You can able to appreciate. So it's a case of a fracture optic canal and post-traumatic optic neuropathy responsible for loss of vision after trauma on left side. This patient presented with a sudden loss of vision on both sides with bilateral Turner palsy with the past history of 15 days severe headache, and this is 2018 we have taken. This patient was a diabetic, uncontrolled with the diabetic ketoacidosis state. There is a mixed signal lesion in the sphenoethmoidal sinuses, and you can see the normal low signal of the right in cavernous ICA. Here you can carefully see the left cavernous ICA is thickened edematous, and you can see the lumen narrowing as well as marginal hyperintense signals. All these things are very classically suggesting it is inflamed going for luminal narrowing. And whenever you are seeing mixed signal areas here, it is suggestive of infective low signal of fungal etiology, probably mucormycosis. So it is sphenoethmoidal mucormycosis has gone to the cavernous sinus and engulfing the cavernous ICA, angiitis of the cavernous ICA, vasculitis, that's why it's producing. And definitely from this is the site where the ophthalmic artery will come. So it will produce ischemic optic neuropathic changes also in the left optic nerve. And this is the infarct. You can able to appreciate infarct in left MCA territory. And you can see the diffusion restricting left optic nerve. This is very, very classical of whenever there is diffusion restriction in the brain, you can see the brain infarcts, and you can see the classical diffusion restricting optic nerve on left side suggestive of ischemic optic neuropathy. And you can see the MR angio beautifully demonstrating the ICA is totally narrowed and the ophthalmic artery is completely occluded in this case. It is a fungal sinusitis with cavernous sinus extension, vasculated ischemic optic neuropathy and POX responsible for vision loss on both sides. This patient, sudden loss of vision, left eye CRA occlusion, and this is the normal targets. And you can see the normal low signal of the right optic nerve and surrounding perioptic subarachnoid space. Here, the left optic nerve is showing bright signals. Here you can able to appreciate the bright signal left optic nerve. This is typical appearance of ischemic optic neuropathy. This is both vertebral arteries in coronal MAP projections, and this is the right side. You can see the CCA, and this is the ICA, and this is the ECA and its branches. This is the right vertebral artery. When I am going towards left side, this is the CCA, and ICA is totally occluded. You can see the ICA is totally occluded, and only ECA I can able to see, and the branches are seen. This is the left vertebral artery. So it's a case of dissection. You can see the left ICA dissection. This is a normal ICA, how beautifully demonstrated over here. You can see the left ICA is totally dissected, and that's why CRA occlusion. And you can see the dissecting intimal flap on this. This is the normal ICA. Beautifully, you can able to see the normal ICA, and this is the both vertebral arteries over here. And this is the dissection. You can able to appreciate the beautiful dissection on left ICA responsible for CRA occlusion, and nicely demonstrating the significant reduction of flow in left ICA as well as the left ophthalmic artery is also not visualized. And ASL perfusion technique beautifully demonstrating the reperfusion changes in the left MCA territory seen as a red color coding in this case. This patient presenting with headache and blurring of vision, diffuse body pain, and we can able to appreciate multiple intramuscular cysticercosis. You can see the myocysticercosis in brain, also multiple ring enhancing lesions with the scolex is also there. And if you are going back to the occipital lobe, beautifully demonstrating the ring enhancing lesion, and you can see the marginal scolex, very, very classical of colloidal vesicle stage of cysticercosis. This is a case of disseminated disseminated cysticercosis with involvement of muscles, involvement of brain parenchyma, leptomeninges. In this case, occipital lobe is also involved by cysticercosis responsible for visual symptoms in this case. Thank you.
Sir, Bhattu sir, can you introduce the next speaker?
Is Dr. Srinivasan here today with us?
No, he is traveling, sir. So he's
there are a host of questions we could have asked him.
No, he has told that we can email to him the questions.
Okay, we will do
whatever.
that.
Yeah, we'll
do that. When Kavita asked me that is there anything you can do to make this session special, the first thing that came to my mind was cerebral venous vision impairment, which is proving to be a greater and greater pressing problem in today's world. More and more children being born in premature nurseries, and children being made to survive who are 600 grams at birth. And many of them have significant amount of brain damage, including hypoxia, ischemic encephalopathy, careless handling in peripheral small nursing homes or home delivery, resulting in significant brain damage of these children. It's one thing to make a diagnosis on MRI scan. It's another thing to actually examine these patients and arrive at a diagnosis of CVI. And if one looks at the statistics, it's becoming increasingly clear that CVI may actually be the most common cause of visual loss. Because it's possible that many of us actually have subtle amounts of CVI. So I was fortunate enough to have these two doctors, Dr. Rebecca Sumalini, who is actually going to become a doctor very soon, Dr. Rebecca, and Dr. Deva Jayaraman, who are excellent professionals from the LVP Institute of Ophthalmology, which is doing absolutely phenomenal work in handling children with visual deficits and of all kinds. And I requested them specifically to talk about cerebral vision impairment in children and how one go about evaluating these children and then rehabilitating them. Thank you, Dr. Rebecca, and thank you, Dr. Deva. We are very eagerly waiting to listen to both of you. And thank you for being very nice and accepting it at the drop of a hat. Thank you very much. And I'd like to pass on the baton to Rebecca Sumalini to proceed with the lecture.
Thank you so much, Dr. Bhattu, for this invitation. I would now request you all to play the video, please. Hello, everyone. I'm happy to be part of this forum and share my experience in assessing children with cerebral visual impairment. Before we get started, I would like to play a video here. This child is diagnosed to have cerebral palsy and has cerebral visual impairment as well. So you can keenly observe to how he is reacting to the visual stimuli that is being presented to him. One thing that you can notice here is if this is the child's response to any colorful visual stimuli like balls in this case, then what about the assessment tools that we have? The black and white stripes, the gratings, or the pictures, optotypes that we show. How can we get some meaningful information from all of this? So this is something to think about while we are going ahead with our discussion. So hopefully by the end of my talk, you all should have an understanding of why is the visual world of children with CVI unique and how to go about the clinical assessment. So cortical or cerebral visual impairment refers to the damage to the retrogeniculate visual pathways, to be specific, the optic radiations and the way up the primary visual cortex, and even sometimes involving the subcortical regions of the brain. Now, this is supposedly the most common cause of visual impairment, both in the developing and the developed countries. So let's discuss the big dilemma here. Is it cortical or cerebral? Cortical only refers to the cortex area of the brain being affected, that the damage is limited here alone. However, cerebral includes the damage even involving the subcortical regions of the brain like thalamus, the hypothalamus, basal ganglia, and so on. So cerebral is an umbrella term. So if one is not sure if the damage is just restricted to the cortical level, it is safer to use the term cerebral visual impairment. We all know that seeing is not equal to vision. Unless we process what we see, we will not be able to make some meaningful information from it. The dorsal and the ventral pathways help us to seamlessly perceive what we are actually seeing. The dorsal pathway is also referred to as the where or the how pathway, and it has several visual processing functions that are listed here. And the ventral pathway is called as the what pathway. So coming to the clinical assessment, where is the roadblock in assessing children with cerebral visual impairment? One is that you may need to move beyond your textbook definition of age-appropriate tests for these children. Given the limited attention span, ensure to always record binocular visual functions first. By the time you record monocular, the child may totally not be cooperative by the time even you move to the other eye. So that is one thing, always try to record the binocular visual functions first. Use appropriate assessment tools in testing environment, given that they are likely to be delayed in other areas as well. And finally, it's preferable to have an experienced clinician assess these kids. So as part of the history-taking procedure, it's important to remember these two C's that are listed here. You cannot get away by taking brief history. In order to understand their concerns fully, you need to keep it comprehensive, covering all the components given here that are listed here below: the birth history, the developmental history, education history, vision-related activity limitations, which is very, very important. So here are some snapshots from the special needs vision clinic history taking form. At the same time, you also need to remember that you need to conclude it with the summary to know which points you would like to address in that particular visit. So the assessment as such can be roughly divided into regular battery of tests and also to understand the higher order visual functioning. So just like for any other pediatric age group, the regular battery of tests like acuity, recording with the most commonly used tools like the letters, symbols, pictures, gratings, they all can be used based on the child's familiarity and cooperation. Refraction, undoubtedly, it's mandatory for all since the prevalence of refractive corrections is very high in this cohort. Similarly, the binocular vision tests are important as well. Few of the children could also have lag of accommodation, so ensure that dynamic retinoscopy is done in those cases. Here in this video, you can see a child-friendly app called Peekaboo Vision. The rest of them are conventional tools, so I didn't end up showing videos or pictures for that. But if you see, this is a very child-friendly tool called Peekaboo Vision app, which is available on the iOS platform. I'll just play this video here for you.
Okay. Very good. Very good. You should
see the child happily responding here. It is very similar to teller acuity cards in a way. So there's a video interactive feedback that pops up once the child presses on the correct side of the greeting. And in addition to this, functional vision assessment component is also important in cases of children for whom we are unable to elicit responses using conventional methods. So here in this slide, we are talking about contrast sensitivity. For measuring contrast sensitivity, one can use Hayden-Cady or Ohio contrast cards, which are more child-friendly. However, it's very important to document the distance at which the child is being tested so that it can be translated accordingly when counseling the parents for home-based vision stimulation therapy. Visual fields are also very important, and they can be tested using confrontation method by using Lea flickering wand as seen in this picture to the left. And pediatric perimeter, this has been developed by one of our scientists from LVPI, and it can be used in very young children as well, and hopefully it will be available for clinical use very soon. In addition to the conventional tests, children may have concerns with one or more of the following visual processing functions listed here, like visual spatial awareness, eye-hand coordination, simultanagnosia, that is nothing but having difficulty in perceiving two or more things at a time. And so just to give you a glimpse of how do we do it here in LVPI, we use a Salient vision integrator in our clinics as both diagnostic and therapeutic equipment. I'll just go ahead and play this video here for your understanding. The child here is performing, the eye-hand coordination module. The SVI, as we call it, Salient Vision Integrator, has several modules to enhance the visual skills of the child, such as eye-hand coordination, dynamic visual processing, visual memory, visual attention, and so on. There's a balance board, probably not shown in this video here, but it ensures that the child is balanced well while performing the visual tasks. In the absence of such sophisticated equipment, using simple tools such as this, a Lea mailbox also can help us understand if the child has difficulty in orientation. I'll just play this video here for you all. So the child is easily able to orient it in the correct direction. But when the clinician changed the direction vertically, the child did not know it until she had a tactile cue. So this gives us an understanding of the child's understanding of the orientation. Children with CVI can also have difficulty in recognizing face expressions, like you see here in the video.
Mia, what is this? Where do you find a smile here? In which card the child is smiling? Smiling, happy.
So this kid was having a lot of difficulty in recognizing the face expressions. Recognition of shapes and sizes can also be tested using Lea puzzle or any other regular puzzles that are listed here. So moving on to simultanagnosia, which I was mentioning refers to the difficulty in perceiving two or more things at a time. So for example, if the child is shown this particular picture, this is called as a standardized cookie theft picture. Herein, if the child is asked to interpret what the child is seeing, they may only be able to interpret parts of the picture, but not the complete picture by itself. Or else even if the child has to pick up some toy from the clutter that is given here, the child may find it very difficult. So it is important to educate the parents about this so that they keep their whole house environment accordingly. So that was a quick run through the assessment. What is your role in all of this? It's important to identify the visual concerns of children with CVI, refer them appropriately. It is said that referral is half the job done. So definitely you have by just identifying and making an appropriate referral. So here are a few resources that you would like to refer to if you want to have an understanding about CVI. I would like to conclude here, and thank you so much for your patient listening. I'm happy to take questions or comments if any. Thank
you. Thank you very much, Rebecca. And that was a brilliant summary of the whole thing. I wish we had a couple of more hours to listen to you. But since we are going short on time, I'd like to call in Deva to supplement your talk or complement your talk, as you might call it. Dr. Deva, could you please take the baton, please?
Thank you so much for the opportunity. So can I request the video to be played? Everyone, and I am very happy to be connected with you all. So good afternoon, everyone, and I am very happy to be connected with you all. So we all visualize one big question in the field after diagnosing the child with cerebral or cortical visual impairment. I just want to briefly explain about how we are addressing this as vision rehabilitation professionals. So CVI is fundamentally different than ocular causes of visual impairment because it requires specialized methods for identification, assessment, and intervention. The assessment decides the phases and the intervention changes for each phase. So the two legends, Dr. Christine Roman-Lancy and Dr. Gordon Dutton, reflect their views regarding the phases of cortical and cerebral visual impairment as shown in the slide. So phase 1 is mainly about building visual awareness, which involves the primary dorsal stream visual function. The children with profound VI due to CVI and additional disabilities begin from this phase. Phase 2 integrates vision and cognition, which involves dorsal and to some extent the ventral stream visual functions. Children with CVI who have functionally useful vision and cognitive challenges belong to this phase. In phase 3, the use of vision in functional academics and everyday living plays a key role, and refinement of ventral stream visual functions takes place. Children with CVI who have functionally useful vision and who work at the expected academic level for their age group come under this phase. So the Cva Range Assessment was designed by Dr. Christine Roman-Lancy for the age group of 6 months to 21 years. It is a functional vision assessment meant for the use of individuals suspected to have cortical visual impairment. And she says it is not applicable for dyslexia, visual perceptual disorders, and visual processing difficulties not associated with vision impairment. So the rating 1 assessment was designed 5 categories as Cva range 1 to 2, 3 to 4, 5 to 6, 7 to 8, 9 to 10. Range 1 to 2 is presented in this slide as an example. The child should be assessed across the 10 primary visual and behavioral characteristics. O represents observation, I interview, D direct assessment. We should tick R if the characteristic is completely resolved. The scoring is based on the pluses, plus minus, and minuses. Rating 1 provides descriptions of typical behaviors associated with each level. And this is rating 2. These are the 10 important visual and behavioral characteristics. These characteristics resolve as the child progresses with the training. We should circle one value against each characteristic. As you move from the 0 up toward the 1, the 0.25 indicates it is just beginning to improve, 0.5 it is halfway improved, and 0.75 it is nearly resolved, and 1 is fully resolved. So the total gives us the score. Rating 2 provides information regarding the extent of effect of individual characteristics. So the use of 2 methods strengthens the validity of the assessment, and we should record the scores of rating 1 and 2 in the phase sheet. We are not supposed to take the average. The difference should be within 1.5 between the ratings. Otherwise, it is an indication that we had gone wrong somewhere. So the score decides the phase. In rating 1, if we score the child 6 and in rating 2, 7, the child is at the end of phase 2. It is expected to conduct this assessment for 3 times over a period of maybe a year or 2 based on the individual's improvement. So what are we going to do for those who come under the broader spectrum of cerebral visual impairment? So there are some inventories developed by Dr. Dutton for different age groups with a set of approximately 50 questions each. So these are based on the mobility, daily living, and academics. It is very important for the rehabilitation professional to decide the right kind of assessment scale and inventory to provide the intervention for children with CVI. So it is also possible to have CVI with an ocular form of impairment. For example, optic atrophy with HIE is commonly seen in our OPDs. So in that case, we should consider the possible CVI strategies along with vision impairment. It is also important to apply assessment scales meant for developmental domains in case of delays. We completed the Cva range scoring or visual perceptual inventory with or without developmental assessment meant for vision impairment. And what next? So we can use the result directly into the student's program while planning individualized family service plan and individualized educational plan with the support of parents and professionals from relevant fields. So these should be implemented and reviewed periodically. So in phase 1 intervention, the overarching goal is to build a stable visual connection. First of all, interventions are based on the principles of visual plasticity. So we have this belief that the brain is capable of using plasticity to activate neurons for vision in the non-damaged areas of brain to connect with one another and to create new pathways, which ultimately becomes new function. So functional vision improvements are facilitated and they are very less chances of incidental learning, especially in this phase. So a light box or a torchlight is not a standalone item. And what is the function of that? We should make a cognitive connection. So those objects in phase 1 often look like very odd kinds of things, but they may become preferred objects for many kids. We can connect these objects for vision plus functions in phase 2. So the mylar or shiny pom-pom that was used in phase 1 may now be cut apart and applied to the targets that can help the child to pair the shyness with something more functional. So red mylar streamers on the back of the toothbrush, a red shiny target on a place where the child locates their lunchbox, a place where the child has red mylar to press a switch to turn on the light when he or she enters into the room, all are vision plus functions. So we should be conscious about the visual and auditory environment, color, light movements, preferred objects while training the child in this phase. And it is common for these kids to fixate on objects rarely, often present latency which prolongs for a longer duration. So when we move to phase 2 and 3, it is possible in some cases to assess the visual functions and impart training as discussed by my colleague. It is recommended to have a couple of training sessions in the concepts involved in the assessment, develop rapport, consider the child's medication and sleep patterns, then go with the assessment. So many kids need multiple sittings of assessment based on the results. The medium and the mode of the education should be recommended after that. So tolerating the visual complexity and improving knowledge through salient features are two big themes in this phase. So one-to-one CVA schedule is very important in learning the concept, and a few group activities for leisure are also very important in improving the social skills. So these should be kept in mind in the areas of literacy, mobility, and activities of daily living. Example for these two themes are presented in the following slides. So how many additional elements can they deal with as they search for target image or object? So we can increase the visual complexity in our everyday scenario at phase 3 and should know how many the child can deal with, 50, 20 or more. So the second major theme is identification of the salient features. For example, a very large animal with huge ears and a trunk is an elephant. So for an elephant, huge ears and trunk are salient features. So they are prominent. So an animal with pointed ears and whiskers is a cat. So these should be taught from phase 2, and these are the examples of salient features in identifying an animal as well as word reading and identification. So this topic is very extensive, and I tried to give the skeleton of the management. Thank you very much for your attention, and my special thanks to Karnataka Ophthalmic Society for the opportunity. Thank you.
Thank you, Dr. Daiva. We're obviously seeing in a very, 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 very small nutshell indeed, a consummation of very, very extensive work that both of you are doing in your profession. It is something which we really appreciate here. And as doctors, when we see a child like that, we unfortunately are not able to relate to them as their parents would, because one of the most important thing is all the parents' aspirations and dreams of a young couple when they get a child with a problem are all completely shattered, and their entire life now revolves around that child. And what we see when the parents come in for a consult is hoping that you can help hoping that the child will be able to move around in society like other children, but knowing at the back of their mind that probably nothing is really, I mean, we are not going to achieve too much with this child. And, at the back of every parent's mind is, what will my child do when my child grows up and when I become old? These are pressing problems. And I believe that I'm so happy to have both of you on board with us today who are directly addressing this need. I wish we have more centers of visual rehab for these children set up with help and guidance from people like you and Rebecca to take us through the maze that and the challenges that these children present to both the therapist, the diagnostician, and the parents. Thank you again. Thank you very much. I'm looking forward to some questions.
Since we do not have such centers around, what is the minimum thing that we can do as clinicians? What is the minimum thing that we can, advocate from our side? So especially as Bhattu sir has told, after seeing such children and parents, we are in low mood or low spirits. So something our mind will say, okay, we should do something or encourage or be a motivation. What is the minimum thing that you would advocate us to do?
Yeah. Hello, Dr. Kavita. Nice to interact with you. Even as part of the general academic sessions that we take in LVPI, the main part that we educate our pediatric ophthalmologists and the optometrists, who, in fact, the special needs vision clinic just came into picture in 2018. Until then, these children were just handled in the low vision clinic. So the main thing that we advocate is, first of all, to identify the condition appropriately, because many a time CVI gets unidentified, and also their visual concerns also that way it gets covered in between. I mean, we spoke about so many visual concerns that these children may have. So I think just being mindful that if we are not able to record, especially about the assessment protocol I was talking, if you are not able to record with the age appropriate tools, it's okay to go one standard down and get some meaningful information from it. Like example I was just mentioning, probably the resolution wasn't clear there, but I was taking the example of the child who was using the app for the visual acuity assessment. Now that child was a 10-year-old kid. Okay. And when she first walked into the clinic, that child was like totally in a chin down position. Later on, we went ahead and gave the yoke prism and all of that, but totally chin down position. She was not ready to, even look, maintain an eye contact and all of that and give a proper response with any of the charts. Then when we established rapport after some time, and then when we introduced the right tool, she was much more, familiar with it. Later on, we assessed with different other tools as well. But if we want their cooperation, I think trying to understand them a little bit, giving them a little time to settle down, which gets very challenging in busy clinics. I totally understand that. I mean, you definitely need some dedicated time for doing it. And later on, the whole point is how all of these assessments can translate into, explaining the parents about what they can do from their side at home, or as part of the therapies at home, home-based visual therapies, and also passing all this information to at least to the network rehabilitation professionals you all have. I think all of these things can be done. The first thing is at least know the rehabilitation centers close to you all where this practice is going on, and consider these appropriate reference. That will be very helpful. Dr. Taiva, would you like to add anything to this?
Thanks, Rebecca. I think you covered everything. And I also just want to mention about the general developmental domains of these kids in terms of vision impairment. We have two sets of scales which can be monitored by the parents themselves. One is Developmental Journal of Vision Impairment, meant for 0 to 3 years, and Oregon Skill Inventory for 0 to 6 years. So we have to look into the CVA features, and while addressing this, we have to concentrate on the other areas of development. Then it works out a bit. And when the kids started moving in phase 2, we have to have a link with the schools which can understand these children, and we can promote the inclusion to some extent. And we are happy. If you are interested, you can connect with us for any webinar or courses on cortical vision impairment.
Oh, thank you so much. That is a nice thing, ma'am. It's a totally different domain which needs complete concentration. You know, we cannot do it as, you know, part-time or something like that.
See, Narayan Nitralaya in Bangalore has set up, again, I would say, a very good visual rehab unit.
I have been there, sir. When Dr. Leah visited, I was there.
Yeah. When were you there?
One Fatima is there. She just inaugurated the center.
Okay. Because I was a medical director of Narayana when Leah made her initial visit to Narayana. And at that point of time, we were doing a lot of work on ROP. It was then that she started putting in the idea of setting up a visual rehab center for premature babies and babies with visual rehab. One thing led to another. And eventually, they did set it up. I'm no longer with Narayana now, but I must say that the dynamic team really set it up. They're doing good work. But, you know, I'm into private practice now, and I do get the occasional parent who says they can't go there every day. What kind of problems do you face there of parents living out of station and they have to come thrice a week, 4 times a week, and 1 hour a day? And, you know, it's taxing, very taxing on the parents too.
We usually do go with home programs. The first visit, we want them to be with us because it is very difficult from the parent perspective to carry the child all the way and pillar to post for all the therapies. Yeah. So it is advisable to have an interdisciplinary team under one roof to get the assessment. Maybe they can take 2 days that time when they come first. Stay with us for 2 days, get the assessment in a relaxed manner. Because the tools which Rebecca projected, it cannot be done in one single sitting. So it takes multiple times.
I understand that this is a process that takes months to years.
Yes. So for the development, we give them the home program, and then we will ask them to contact us through tele-rehabilitation.
In fact, I should ask Dr. Anand Vinikar, who actually was the spearheader behind the movement to set up a rehab program in Narayan Nitralaya, what else they are doing, which we could actually, as doctors in the vicinity who see such children, could access. Next time I do talk to him, I'll ask him. And thank you very much. And we'll probably be seeing more of you in the conferences to come, Eva and Rebecca.
Thank you.
And that was an excellent presentation, and much obliged. Much obliged.
Thank you.
Thank you. Thank you so much, both of you. So should we end the session?
Are we running?
Yeah, we are running late. We are running late.
Okay, if we are running late, then I don't know whether we can continue with question answers, because we can go on and on. I have written actually about 5 or 6 questions for each speaker right now, but I don't think we can do it in this time frame, because then we have another oration to start. So
probably we could mail to them and get, maybe the questions can be posted in the group.
Yeah.
The WhatsApp group.
If you have any questions that can be posted, that will be nice.
Yeah, we'll post it in the group and they can.
Would you like to, Kavita, would you like to end the session?
Yeah, I thank all the speakers, Dr. Mahesh, Dr. Naveen, Dr. KG Srinivasan, Dr. Bhattu, most importantly, Deva and Rebecca for such a wonderful and elaborate insight into each topic. Of course, this was, the session was given as 1.5 hours, but we have exceeded 2 hours now. I thank once again for sparing your Sunday time for us. I'll personally thank you again. Have a nice day.
Thank you. Thank you.
Thank you very much, all of you. And have a very nice afternoon and a weekend.
Thank you. Thank you, Bhattu sir.
Thank you very much.
Thank you.